right. Well, thanks for having me back again this year. I always enjoy speaking to this group because, as we know, there's just not enough attention happening for male breast cancer. So, we're really appreciative of Brett and Peggy and all that they do in the community, to really get the word out about male breast cancer and how it definitely happens. So, I usually give some updates on male breast cancer imaging and research. So that's what I'm going to do. And we'll go from there. So, a lot of this might have been shared today, of course, but, male breast cancer on the whole at this time, it is still rare in the sense that 1 out of 8 women are diagnosed with breast cancer in their lifetime. Men, it's about 1 in 800. Here I have a statistic 1 in 833. But just because it's not as common, we shouldn't discredit the fact that the incidence of male breast cancer is rising. When you look at the American Cancer Society statistics from this year, and I'm, really proud to be chair of the ACS Kansas City board. So we, are reviewing a lot of this stuff all the time. And there are the 2023 estimates of male breast cancer, about 2,800 new cases of invasive cancer. And, the last time I reported to you all was 2020 statistics, and that number was lower. So it just shows the fact that the incidence is increasing. About 530 men in the United States will die from breast cancer. So that's not including the world. We know still that the most common breast cancer we see in men is invasive ductal carcinoma, where the breast cancer comes from a milk duct. Ductal carcinoma in situ is also one that we see in men. And then invasive lobular carcinoma is something more rare that we see in men, given that men tend to not have very many lobules. So usually of the ductal variety is the most common. Isabella, I'm sure, had talked a lot about, the genetics aspect, but there is, of course, an increased risk in certain mutation carriers, such as those with BRCA2, which also has an association with prostate cancer. Then, of course, there's a lot of different risk factors that put you at risk for male breast cancer, different syndromes like Klinefelter's and Lynch and Li-Fraumeni, and just a family history as well. So, okay. So again, I'm sure Isabella talked a lot about this, where we are seeing, evidence linking genetic mutations. I talked about BRCA2, BRCA1, the ATM gene, CHEK2, PALB2. Now, what we are learning, so research has identified like several genetic variations associated with breast cancer risk. And that the variations that are being identified, they affect risk in different ways for men and women, but still, it's still very vague, like in what sense that the variations affect men and women differently. And the bottom line of this is that there's just so much more research that's needed to really look at the differences from a genetic from a genetic point of view when it comes to men and women. So, it's kind of sad. So, since COVID in general, research has really suffered, and we've seen sort of a quite a decrease in the amount of like novel scientific research publications. And hopefully, as we kind of recover from the aftermath of COVID in the healthcare sector, we will see more published. But as far as me doing a kind of a recent literature search and just from talking to colleagues, the most recent studies on male breast cancer, here's a couple that have been discussed. 2019 at Vanderbilt University, which I believe you're going to have a physician from Vanderbilt speaking after me, so maybe he'll be able to talk about this. But this study basically performed at Vanderbilt, analyzed mortality data from 1.8 million women and a little over 16,000 men who had breast cancer. And the male breast cancer patients, they had a 19% higher breast cancer death rate or mortality rate than women. So that was a pretty startling statistic right there. Unfortunately, we know that a lot of times when men present to us, it's with a lump or a suspicious mass that it's already progressed quite a bit. Tends to be more aggressive in men when they present to us because sometimes first of all, there isn't, screening in men. Second of all, a man might feel something kind of disregard, like, oh, it's nothing, it's nothing. And then by the time they present to us, it's already spread. And then, of course, there's a study that was published in the Journal of the National Cancer Institute in this year. The authors were from multiple institutions. And basically, they reported that unlike breast cancer in women, unfortunately, survival rates for males have not significantly improved in the last 30 years. So that's really, disconcerting given how that longevity of years, and we still haven't seen an improvement in breast cancer death rates in men. So all of this truly highlights we still have a lot of work to do when it comes to male breast cancer and research. So, in my world, when we deal with male breast imaging, we still don't have widespread screening recommendations in our field. And that, again, is because we just don't have enough research that's being conducted on this. So, basically, the screening really varies per practice and institution in high risk men. So, some institutions will do, annual mammography, some might do every other year. Some may also, occasionally screen with provide supplemental screening in the form of breast MRI. So it really does vary everywhere. So you want to try to, go if you are someone who is high risk with breast, has had breast cancer or has strong family history or is high risk for breast cancer. You want to go to a breast imaging center where they have an actual protocol in place for screening, because a lot of places unfortunately don't. And then as far as imaging, if you're a man and you feel a pain or palpable or like a lump, usually if you're under the age of 25, we start with an ultrasound. And then if you're 25 or over, we start with a mammogram. And then we may or may not do an ultrasound depending on what we see. The most common lump or pain symptom we see in men is something benign called gynecomastia. And in those cases, a lot of times you can tell it's gynecomastia on a mammogram and you don't need to go to ultrasound. But sometimes, it may not be gynecomastia and you need to do the ultrasound for further evaluation. So basically, the same modalities used, such as mammo, ultrasound, and MRI, that we use in women, can be really useful in distinguishing benign versus potentially malignant pathologies in men. So, male patients with symptoms of gynecomastia, typically imaging really isn't appropriate. It's usually a clinical diagnosis, but a lot of times primary providers will just send a man for a mammogram just to confirm that's what it is. If a man is 25 years of age or older with a lump, I already talked about, a diagnostic mammogram is done. And if it looks suspicious or doesn't, 100%, you can't 100% say on the mammogram it's benign, then we send the patient to ultrasound. If they're younger than 25 and they have an indeterminate lump, then they go to ultrasound. And if it ends up looking suspicious, then you may have to backtrack and do a mammogram. And then if there's, any age, if you have a suspicious lump, particularly, in the armpit axillary, worried about lymph nodes in the armpit. If you have any nipple discharge or retraction of the nipple, then the patient will get a mammogram and ultrasound. So this is kind of like, and many of you may already know this, but this is a classic example of a male breast cancer. So this is a 50-year-old male, and he was feeling this lump in his left breast. So here's the mass, and it's sort of adherent to the chest wall, because this is your chest wall muscle on this mammogram here. And this triangle marker it denotes that he's feeling this big mass here. And the nipple is actually down here. So it's pretty far back and worrisome for a cancer. And then this is what it looks like on ultrasound, have this sort of, a dark mass here. Our, terms for it would be like an irregular, indistinct hypoechoic mass. Those are some technical terms, but this is a classic textbook example of a cancer. And you can see the same finding in a woman as a man. They present very similarly. So this was an invasive ductal carcinoma, and it was a high grade. It was a grade 3. So typically, invasive ductal carcinoma, not otherwise specified, is the most common breast cancer we see in both men and women, and clinically tends to be non-tender if it presents as a mass, firm. But sometimes, breast cancer can be painful, but on the whole, it typically presents as non-tender. On the mammogram, it might be subareolar, or it could just be off the side or eccentric to the nipple. And it can have, again, a similar appearance to breast cancer in women, a kind of an irregular mass that has jagged edges or is spiculated. Same thing on ultrasound, as I showed you those images as well. So, there is more evidence that suggests that high-risk men should be routinely screened, but again, more research is needed to conduct. It needs to be conducted to make sure this is a standard of care measure. But again, if you are high risk, try to go to a breast center or institution that has high risk screening in place for men, or a protocol at least, so that you have some guidance on that. But there is, of course, a big push from the breast imaging community to focus on male breast imaging and cancer research. And there is a lot of great research underway. It's just a matter of, once we have enough data to publish at different institutions, it'll be interesting to see in the years to come what research is gleaned from that. So this was a more recent study from NYU, where basically it was a 12-year longitudinal study of male breast imaging utilization and outcomes. And basically, they found that mammography screening in men yielded a cancer detection rate of 18 per 1,000 exams, higher than cancer yield among women, with an average risk of 3 to 5 per 1,000 exams. And then mammographic screening depicted clinically occult breast malignancies in men with high risk, all of which were very early stage, that improved their prognosis with this imaging. And then there were risk factors such as personal history of breast cancer, Ashkenazi Jewish ancestry, or having genetic mutations, or a first-degree family history of breast cancer. So this is just showing a mass here that's kind of subareolar that ended up being a cancer. So just kind of closing out some ways you can lower your breast cancer risk, and this applies for both men and women. Getting to and staying at a healthy weight is really important. We know that obesity is a pretty significant risk factor when it comes to developing breast cancer. Avoiding or limiting alcohol. If you're going to limit alcohol, no more than 2 drinks per day. Physical activity. The American Cancer Society recommends 150 to 300 minutes of moderate intensity, or 75 to 150 minutes of vigorous intensity exercise each week. So that's kind of what ACS is recommending at this time. So in conclusion, although male breast cancer is rare, like I said, the incidence is rising. So any symptoms you have shouldn't be ignored to ensure proper evaluation. So again, we need to push as a community to for more research to occur for male breast cancer, and advocate for widespread acceptance of regular mammography screening in high-risk men. This is something that needs to be covered, particularly by insurance for these patients, and is something that we need to focus on in the years to come. Thank you for your time. Here's my email. If you have any questions or comments you can think of after today, but I appreciate your time, and I'm happy to answer any questions you might have.
Hi, Dr. Patel.
Hello.
Thank you for your presentation.
Yeah.
So I got a question. So for males who have had breast cancer and are sort of finished with active treatment, what type of imaging would be best for monitoring or for checking for recurrence?
Sure. So it depends. Have you, this patient, they have like a mastectomy, a lumpectomy?
Mastectomy and chemo, that kind of thing.
Okay. Yeah. So, particularly it really is kind of like I said, it really varies per institution, and it really depends to, you know, patients who have a mastectomy sometimes still have a lot of breast tissue left over from the surgery. So a lot of times we can assess if there's enough tissue there to do a mammogram annually or every other year. Here we do them annually if you do have that history. But if there's really not a lot of breast tissue there, then particularly, and you're just not able to have the mammogram done, you can do a breast MRI as well as a supplement. Breast MRI is our most sensitive supplemental screening tool, but it can be useful, particularly in situations like this. So we'll even have, women patients that have really no breast tissue and are just really nervous and want to be watched every year. So we just go ahead and do a breast MRI. So I would say, we for a man, definitely mammography every year if we can do it. If we can't do it, then there are other modalities like MRI. Ultrasound, is becoming a less sensitive modality. We're finding particularly like we were doing whole breast ultrasound for women who have dense breasts. And, ultrasound is having, we're seeing a lot of high rate of false positives, which leads to unnecessary biopsies. So MRI is really something that's picking up steam. We are seeing really good cancer detection rates with the full MRI, which is a full sequence scan, and with the abbreviated breast MRI, which is a quick, anywhere from 11 to 20-minute exam. Similar cancer detection rates of about 15 to 18 per 1,000 scans. So that can be a really great substitute as well if you're not able to get your mammogram.
Great. Thank you.
Mhm.
Any other questions? If not, then I'd just like to say thank you, Dr. Patel, for your presentation and just everything you kind of went over. Just kind of gave me a little more reassurance of my yearly checkups with you now.
I'm watching
And
you like a hawk.
and it was interesting to see a few of the things where you were talking about over 25 and under 25. Since when I was 24, I was sent to an ultrasound first, and then there
Mammogram.
was the suspicion of the lump by the radiologist goes, hey, let's go do a mammogram right down the hall. Then you don't have to come back in and take any more time off work. So
Sure.
it's just interesting to see that kind of laid out, and it just kind of brought back a little bit of a flashback. So
Yeah.
but thank you very much.
Thank you very much.
Yes, and Amy, we thank you for always keeping a close eye on our family. She checks Brett and I both. We go in together, so it's
Always.
amazing. Absolutely.
It's my honor. You two are very inspirational.
Well, and you're the best Chiefs fan around, so that's all that matters.
Yeah.
Fan of the year last year for the Kansas City Chiefs, Dr.
Yeah.
Amy Patel. She's
Well,
good.
thank you
She's just
so much.
awesome. We can't thank you enough for all you do. We appreciate you.
Likewise.
Excellent. All right. And then Brett, and especially we thank you for your sponsorship from Liberty Hospital of sponsoring this today.
Of
We
course.
can't thank you enough for that and helping us to get the word out globally. It really works.
Yes.
So thank you. Thank you.